Thank you. Thank you very much, and it's a great pleasure to be here. Here are my disclosures, and you can see a full version of them online. So I think a very good question is, why bother in 2022 to individualize therapy? Surely you have to personalize drugs because they're bad. And when we've got good drugs, there should be no reason to do it. And you know, if you look at the reasons why we used to individualize drugs instead of giving everyone the same dose, it was either because there was an efficacy problem, viral load less or greater than 100,000. But we're not in that area now. We're not introducing new drugs that have these characteristics like rilpivirine and abacavir. Or there was a safety alert, and I think the new drugs that we have now are so much safer with some caveats, including weight gain. And then there's PK variability, whether it's in complex populations like pregnant women or children, or else a pharmacogenetic element. The drugs now are so much better. And I think if you had a drug in preclinical development that had a huge pharmacogenetic effect or a question about high viral efficacy, I think that people would kill it in drug development. It would not survive preclinical evaluation. So the one thing that hasn't changed, I think that's still with us, is the issue of drug interactions. And I'll show you some data around that, although there's signs that that might be changing. So I think the bottom line is that we are now personalizing drugs or individualizing drugs, not because of the characteristics of the drug, but the characteristics of the patient. And that's a very important thing. And the rest of my talk is going to be around tailoring the drug to the patient because of the patient characteristics, okay? So here's what we said before, I think for some of you, I hope some of you online and here will be familiar with our website, which I'm going to refer to, the Liverpool website, hivdruginteractions.org. So back to what we said, in the old days we had drugs that had lots of caveats attached to them, and as Caroline's shown, the newer regimens have very few caveats attached to them. So actually one drug for the same drug at the same dose should be appropriate for most people. And you can see that in drug interaction liability over the years, as we've got better drugs, the liability for drug interactions is much reduced. This is work that Caroline and her colleagues have done from POPPY. I'll be referring to quite a few studies on POPPY because that looks at, I think, one of the most important issues around our patient characteristics, and that's around aging and multimorbidity. So POPPY is a big study in the UK looking at HIV positive patients over and below 50 years of age and an elderly HIV negative matched population. And exactly as in the HIV negative cohort, you have disease clusters. So there's a cardiovascular cluster, you can see down here. There is a cardiometabolic cluster. So there's a cardiovascular cluster largely driven by ischemia, the cardiometabolic cluster driven by metabolic syndrome, insulin resistance, hyperlipidemia. There is a mental health cluster, very often linked to other things as well as a poor sleep, anxiety, chronic pain, and then an STD cluster. And the comorbidities cluster, but also the co-medications cluster. So data we showed at EX a few years ago is when you look at the mental health cluster, you look at all the drugs that are used in mental health cluster, or the cardiovascular cluster, or the metabolic cluster, you can see that a boosted PI regimen or elvitegravir, nearly 1 in 3 to 1 in 3 patients at least will have a significant drug interaction. And with modern regimens, that's gone, okay, that's gone. And it doesn't matter whether you've got 2 drugs or 3 drugs. People try and tell you 2 drugs have less interaction. That is not true. Your regimen is as clean as your dirtiest component, okay? And so you can see that all the modern regimens we use nowadays are pretty clean. So that could be the end of my talk, but it isn't, because Daryl Hodge from our group has looked at the prevalence of drug interactions over 3 decades in the published literature. And surprisingly, the prevalence of drug interactions has hardly changed, okay? Hardly changed in 3 decades of antiretroviral therapy. The relative risk of the drugs has gone down. I showed you that in the previous slide. But the absolute risk of drug interactions remains high because we've got an aging patient, largely driven by an aging population. And so I'm going to be asking the question today, are the right people getting the right drugs, okay, which is what actually treatment optimization is about. And if you look at the data, it's all the same old culprits. It's been steroids for the last 15 years, particularly non-oral, injectable and inhaled steroids, quetiapine, statins. It's the same culprits, okay? So that's the prevalence of drug interaction. Not everyone who has a drug interaction is going to get harm, okay? And some people are more liable to harm than others. So people in whom the drug interaction studies, for example, are carried out in healthy people, but the harms happen in unhealthy people, all right? So people with compromised kidneys or elderly, frail. And so here's a situation where the interaction is qualitatively similar but quantitatively different. And you all know the risky situations and the vulnerable people. I hope most of you are familiar with the Liverpool Drug Interactions website, but most of you probably just use the interaction checker in top. And I wanted to draw your attention to one section that we've put specifically to deal with these issues of complex patients. And so if you look in there, you'll find everything that I have in the talk today around, for example, treating people with GI surgery who can't absorb, people who have swallowing difficulties, which tablets, which formulations are available in syrups, which are crushable, which are not crushable, food effects, renal impairment, and then choice of different drugs as well. So there's a whole lot, including elderly, multimorbid patients. In the terms of geriatric medicine, we have a lot to learn. There's a lot of good science going on in aging and multimorbidity. And this is some very old data that everybody's familiar with, the use of potentially inappropriate medications. There are plenty of lists for this, but best known is the Beers criteria. And these include drugs like diazepam, amitriptyline, and a lot of these drugs have potential for doing harms as well as good. So here's a study that looked, this is a large insurance database that looked at, it's Thomson Reuters, that looked at the presence or absence of an inappropriate medicine on the Beers or NCQA criteria, and the risk of hospitalization by stage. And the stage is a stage of complexity, which is a tool used by the insurer. Okay, and so as you became more complex, in fact, at every stage of complexity, you have roughly a doubling of risk of hospitalization if you have a presence of an potentially inappropriate medication in an elderly cohort. Okay. So there's plenty of talks on pharmacology in old people, and I just want to clear up a few misunderstandings. So if you look at the textbooks, there are plenty of theoretical reasons why old people might have different PK. And that is true. So body distribution, body fat, renal function, liver function, etc., okay? And some of these are more theoretical, such as compartments, than actual. There are some good data because clearly your EGFR goes down as you age, and drugs that are cleared renally will have higher exposures. And that is certainly true. Data from Poppy, again, showing 4 nucleosides, 3 of which are renally excreted, so tenofovir, FTC, 3TC, and you can see that the highest quintile of drug levels, okay, is associated with the biggest drop. These are cross-sectional studies, a biggest reduction in EGFR, okay? But the one drug that is not, abacavir, which is hepatically cleared, there was no significant effect. So there are plenty of old people with actually normal kidneys going around. So actually, aside from renal function, does aging affect PK? And the answer is not a lot because there's so much variation anyway. PD is the big thing. Elderly people are more sensitive to toxicities, more unable to compensate. And so the therapeutic index is actually reduced in that sense. And the best example here is amlodipine. Some of you have seen this slide. It's a slide I show a lot where the young people in black dots, the old people in triangles. And at the same plasma concentration of amlodipine, you can see a bigger blood pressure drop in elderly people. So elderly people drop their blood pressure more, and then they have poor balance. There's no baroreceptor. They have osteoporotic bones, so the consequences are worse. And then one of the big things around is anticholinergic burden, and there's plenty of data from the geriatric literature and the HIV literature And this is some data presented again from Poppy, looking at falls and frailty as a consequence of an anticholinergic burden. So if you've got an anticholinergic drug, so these are largely SSRIs or loperamide or drugs for prostatism or diazepam, okay? If you're on those drugs, then you have an anticholinergic medication. If you have an anticholinergic medication, then the uncorrected analysis certainly shows, unadjusted analysis shows a significant association with falls and frailty, and that reduces when it's adjusted for things like demographics, lifestyle, other clinical factors. And if you look for dose relationship, as the Poppy investigators did, by the number of anticholinergic drugs, so the overall burden increasing, you see a dose effect as well. And this is borne out by many, many other studies. So one of the problems with anticholinergic effects is that it's a consequence of prescribing cascades. So you read all about this in medical school. You get a condition, you get a drug, and then that gets a side effect, and you add another drug, and you add another drug. And these cascades are well mapped out, okay? And there are certain clusters of cascades, and these cascades cluster. So we talked about disease and drug clusters. These cascades also cluster. So can you imagine trying to identify that from 100 patients in clinic? You can't, can you? But now people are developing AI tools to try and look at the temporal sequence, because these follow a certain time, to identify clusters. And there's some very exciting work being done in geriatric medicine, which is applicable to HIV, and I have colleagues working in that area. Many of you are familiar with a lot of different frailty tools. This is one that we use a lot in the UK and the NHS, sometimes correctly, sometimes incorrectly. This is the Rockwood scale, and you can see very good data from the UK on survival analysis by this 9-point frailty scale. And the way that it works is that you've got a bunch of people who are very fit, 1, 2, 3, okay, doing well, and a bunch of people who are very frail, 7, 8, 9, okay? And then you've got a bunch of people in the middle who are pre-frail. Now, the very fits and the very frails tend to stay fit and frail, okay? But what I hadn't realized is that there's a lot of mobility between the pre-frail. People can go up and down the scale. It's not permanent. And this is really important, because it's in this mobile group actually that tailoring your HIV medicines is the most important. Because if you don't do it, then you get irreversible effects that push them into a state of frailty. Okay, so you've got drug interaction, you've got anticholinergic burden, you get postural hypotension, you fall, you break a hip, and then bang, you're in an irreversible state of frailty. Whereas if you anticipate that, and preemptively manage the DDIs or deprescribe, you can actually do something about it. So this is important, and this is an argument. So in the UK, what we found from the climate data is that young people who are more recently diagnosed go on to integrazers and fix those regimens, and the old people who never complain, who are virologically suppressed, are the ones who are still on protease inhibitors and efavirenz. So the wrong people are getting the wrong drugs. All right, and I'll finish on deprescribing. So there are many trials of deprescribing. They all have one thing common. They're all a lot of them underpowered. Most of them under-recruit, and of the ones that do recruit, the physicians don't listen to the advice, okay, and they still, so it's a really, really difficult area to do. But here's one study that caught my eye, which was this, with statins. We know that a huge meta-analysis of statins says you need 2.5 years for a statin to have an effect. So what the doctors did was they went to the GPs and they said, they did a would you be surprised test. Would you be surprised if this patient died in the next year? And if the answer was no, you stop the statin, okay? Simple as that. And it was a really easy study to do, and there was no difference in mortality, as you would expect, and an improvement in quality of life score, and of course, reduction in treatment burden. So something we could learn from in the HIV world, I think. Now, on to the thorny issue of long-acting cabotegravir and rilpivirine. There are differences in Europe and the US here. So you of course all know the Atlas and the Atlas 2M data and FLAIR, and we know that monthly and 2-monthly injections are efficacious, equally efficacious. There's some data from 152 weeks for two monthly from Atlas 2M presented at CROI. In Europe, the EMA has licensed both the monthly and the 2 monthly injections. The doses are different, but only the 2 monthly is marketed. Okay, in the US, you've got the choice of monthly or 2 monthly, and we'll come on to whether this matters or not. Just to remind you, so the studies use an oral lead-in phase of cabotegravir rilpivirine. Then for the monthly, there was an IM loading of a higher dose of cabotegravir and rilpivirine, so 3 mils in each buttock, so 3 cabotegravir, high dose, and then thereafter you go to a 2 mil dose times 2 for every month for cabotegravir and rilpivirine's lower dose. For the 2 monthly, you have the oral lead-in, you have the high loading, you have a second loading on the second consecutive month, and then every other month after that, you have the higher dose of cabotegravir and rilpivirine, and the advice in both cases is that high adherence is recommended. There's counseling, and you shouldn't miss your injections by ±7 days. There is some advice on what happens when you do miss your injections. So if you've missed your injections in the monthly dose for less than 2 months, then you give the next dose as soon as possible. But if it's greater than 2 months, you have to repeat the induction. You have to reload the patient. Similar thing for the 2 monthly, next dose as soon as possible. If it's greater than 2 months, then you have 2 inductions you need to repeat, and then on to the continuation regimen, okay? Things are starting now to look a little bit complicated, aren't they? Okay, so let's look at the pharmacology. If you give cabotegravir and rilpivirine orally, monthly or 2 monthly, you get very different C troughs, which are the important things. So orally, you get a cabotegravir C trough of 4,500 nanograms per mil. Okay, in monthly, intramuscularly, it's 2.8 micrograms per mil, and intramuscularly, every 8 weeks, it's 1.6. So you get a 43% reduction in troughs between the 2 monthly versus the 1 monthly for cabotegravir. For rilpivirine, it's less. It's a 23% reduction in troughs from the IM, but both are lower than the oral. Okay, so does this matter? All right, now ordinarily you'd expect to say the clinical trials show that it doesn't matter. All right, but the clinical trials had a high selectivity. Okay, there were many exclusions. We'll talk about that. Adherence was one of them, of course, like it is for most trials. And so what we're lacking is real-world data. I've heard many talks on long-acting. I've given some talks myself, and I still have no sense of how this is going to pan out in real life. There are many questions that are unanswered in my own mind. You would expect that 2 monthly regimen, for example, will be less forgiving for adherence, potentially. Less forgiving for drug interactions, potentially. But in the license for treatment, that's not reflected particularly. In the license for PrEP, it is. So with cabotegravir, if you're on 2 monthly PrEP and you're taking a moderate inducer like rifabutin, then you take that higher dose every month until you stop the rifabutin. Okay, so that's a licensing. But if you're taking cabotegravir for treatment and you take rifabutin, it's contraindicated. All right. Okay, so there are some differences that are emerging. All right, what about not just the PK? What about PK but with effect of BMI and needle length? Okay, so some very interesting data coming out now, and some of this was presented by Emily Elliott at EX last year. And so this is the PK of rilpivirine in blue and cabotegravir in green. In people with BMI of less than 30, bold lines, and greater than 30, dotted lines. And you can see that rilpivirine is not affected by BMI, and you can see that in the monthly and the 2 monthly PK profiles. Cabotegravir is, okay, so there's a reduction of cabotegravir in people who have a higher BMI, and you can see that in both the monthly and the 2 monthly. And if a lot of that is because the needle length is too short, so you're giving a subcut injection rather than an intramuscular, deep intramuscular injection. And if you see that if you use a longer needle length, which is not the needle that's supplied in the Vocabria or Cabenuva box, so a 2-inch needle, you can overcome that BMI effect. So I think there's some important operational issues to deal with here. All right. This, I think, was referred to by Danielle earlier on, the issue around people at high risk of failure. So if you look at pooled analysis from Atlas 2M, Atlas, FLAIR, the confirmed virological failure is very low, actually. But there are risk factors, and it's a combination of 2 or more risk factors of a BMI of greater than 30, and then the prevalence of rilpivirine resistance mutations and HIV subtype. And so this is starting to work its way into guidelines, which makes this quite a complex area to look at. All right, and I'll finish, I think, by the things I don't know. So we've known about needle length. We know that actually there are good things about injectables, particularly around adherence, and particularly also around avoiding GI-based drug interactions. So things that affect gastric pH, like rilpivirine, or divalent cations, such as affecting cabotegravir. These can largely, can be completely and successfully avoided by IM administration. If we know that we're going to miss a dose, we can bridge it with oral therapy, so that's useful. But there's lots of things we don't know, actually, real-world data. Okay, so operation delivery, how often do you monitor viral loads? So in the BEVA consultation guidelines that Caroline mentioned, said, well, the clinical trials used 2 monthly viral load monitoring, and that's what the guidelines should mirror until we know, we have a better feel for this. What about the unanticipated missed doses? You know, how do you do that? And to me, the big issue, I was interested in Daniel's talk about this, is this likelihood of successful resuppression. So you know that with a PI-based regimen, if someone goes away and they disappear for whatever reason, they come back 4 months later, having had a treatment interruption, you give them PI, your chances of resuppression are very, very high. There's data coming out of Advance now showing that actually dolutegravir-based regimen, TLD or TAF-LD, people resuppress equally well when they re-engage. But we don't have that data for cab and rilpivirine. And one of the worries about that is that most of the failures, so the failure rates are low, but the consequences of a failure is high because people who fail tend to have resistance mutations to either rilpivirine and or the integrase. Okay, so what's the likelihood of a successful resuppression, and how do you handle treatment failures? You know, it may be that you'd have to give everyone who fails that eventually something like Simtuza, for example. Okay. People are going to use Cabenuva in an unlicensed way, and there is going to be a temptation to use this to bridge perioperative scenarios. You're going to get big major GI surgery, you're going to get an ileus, can't absorb drug, what do you do? People will be thinking about using that. There's no data, completely evidence-free. How would you use that, okay? How do you give injections to elderly people with sarcopenia? You know, how many of those can you give, and what's the tolerability in those patients? What's the long-term safety with a DOAC? You know, every month, every other month, 3 mils. What's the chances of bleeding, and what does that do to your PK, and what does that do to patient tolerability? You know, there's plenty of unknown questions still in this, and we haven't even got to cost yet. So I think we do need real-world data. So I'm going to finish now, and thank you very much for listening. And a restatement of the obvious, really. I think that, as my colleague David Berger says, the most dangerous drug interaction is the one you don't know about. And so I think we have to do a full medicines reconciliation, and the steroids, the contraceptives, the traditional medicines, the recreational drugs. The BEVA guidelines incidentally say you should do this once a year and at every therapeutic crossroads. Okay? Narrow therapeutic index drugs, the DOACs, antiarrhythmics, the hypoglycemics, the quetiapine, for example. Appreciation of the differences between ritonavir and cobicistat. So ritonavir is a mixed inducer inhibitor. Cobicistat is a pure inhibitor. So things to watch out for: dabigatran, where ritonavir has a mixed induction and inhibition, so it stays about the same. And cobicistat, where dabigatran just goes off the rails and it's actually contraindicated. Or methadone, where ritonavir can lower the levels of methadone, but cobicistat does not. And things like, for example, estrogens, estradiol, because ritonavir induces glucuronidation, drops the level of estrogens, cobicistat pushes it up. Okay? The understanding of the offset of induction and inhibition. So we've seen this. If you stop an inducer, it takes about 2 weeks for the levels to get back to normal. So the WHO guidelines last year on the consolidated guidelines said that you had to keep your dolutegravir levels high for 2 weeks after stopping rifampicin, something not appreciated, I think, in a lot of cases. And with COVID, we've seen that with Paxlovid, stopping Paxlovid, the inhibition takes about 3 days for the inhibition to go because it's an irreversible binding to the enzyme. Okay. Unrecognized pre-frailty, and the one area that my practice has changed most of all is in preemptive switching. So I see a frail patient asked, do you fall? And if I hear that, then I look at their drugs, and whether they are tolerating it or not, I'm tending now to switch them to an integrase inhibitor. I think preemptive switching is a big area that's neglected. And then I'm not going to talk about the new morbidities that are emerging. And I'm going to thank all my colleagues at Liverpool who do a fantastic job and actually know much more about this than I do. Thank you very much.